Good evening, everyone. I'll be talking about the percutaneous fixation of scaphoid, some surgical tips which you have learned over a period of time. I think surgical tips basically should be divided into two parts, when to do it and how to do it. So when to do is a very important thing, especially when it comes to percutaneous fixation, because we provide percutaneous fixation only for undisplaced and mildly displaced fractures. All the displaced fractures, we always do an open reduction because we feel that when you are doing an open reduction, you have a better control, you see it well and you fix it well. Now, problem is all these undisplaced and minimally displaced fractures of this kind are also a perfect candidates for doing a conservative treatment. So there is the main controversy about whether to do a percutaneous fixation or not, because many of them can be as effectively treated conservatively. A very big study and multiple studies by Dr. Dice, he actually comes to conclusion in all of them that it is good to not treat these patients with the screw fixation, and conservative treatment is equally good. That is nice if you are doing a study in a setup like NHS where the patients don't have much choice. But when you apply this to generalized population, I think there are many studies which say that if you want a patient to go back to work early and a patient does not want a cast, it is a nice operation to do. And it makes a lot of difference to those patients. Now take an example of this lady who has a small baby to nurse, and she has a bilateral scaphoid fracture. It is undisplaced on both the sides, but such a patient, if you put a cast for 2 to 3 months, she's going to have a lot of problems with that. A student who is going for 12th class exam and comes with a scaphoid fracture, he cannot write an exam with the fracture, the plaster on. So these are the indications in which percutaneous fixation can be really a game changer, and it is quite effective in these patients. So these are the indications in which we offer a percutaneous fixation. Proximal third fractures, because they have high chance of going for non-unions. Bilateral fractures, patients who are not willing for a cast for 8 to 12 weeks. This is quite a controversial thing because most of the patients would tell that I don't want a cast. But then we have to gauge it according to what work the patient is doing and what kind of fixation you are able to provide. We have observed that many of the IT people who are going to many of the big conferences, they feel that cast is a hindrance to their work, but they all do office work and they don't have much demand. And also doctors who are sitting in their outpatient clinic, they also don't like cast-ons. These are the most frequent patient in our situation when we have offered them a percutaneous fixation. Now coming to the surgical tips, the surgery as such, I think the most important part and which has actually led to most of the complications while doing the operation is not knowing the instrumentation well. We need to know the instrumentation quite well and first itself be familiar with that. We usually use this headless compression screw which is applied by Synthes, but any of the screws can be used and they work equally well. Knowing this compression screw is quite important because this is not like a typical Herbert screw in which the differential pitch alone is doing all the work. Actually, if we go into the detail of the headless screw, it says that when you put this special screwdriver, which is called as a coupling device on top, it converts the screw into a normal screw like with only thread on one side. So actually the Synthes screw is a lag screw once the compression device this is put on, because it takes away all the threads over here. It acts like a head, and when we are tightening the screw, the coupling device goes and touches the bone and achieves the compression. So that's why this coupling device is must when you are doing this operation. Otherwise you may not get a good compression. Only the final compression comes by the second thread which is present proximally. We should make sure that the guide wire is going easily inside the screw and inside the drill. And one of the other important technical point is whenever you are using a 1 mm K wire, it is quite flexible and you are not able to direct it well into the bone. So use a 16 gauge needle as a sleeve. This also will protect the soft tissues and will allow you to easily maneuver it into the bone. Very important to know that only 1 mm K wire or a guide wire should be used because more than this will not go inside the cannulated screw. Now using the needle is quite effective because it allows you to have a firm access to the entry point. You can see over here, this is not good, and then you can adjust it and then just put a wire across inside the needle. Now, which approach to use, a dorsal or volar? There was initially a lot of discussion on these, multiple papers. It has been found that the dorsal approach allows a more central axis of screw. Volar allows a longer screw, which both have been found to be good. But a generalized meta-analysis done recently has found that both the approaches are quite okay. And we generally do a volar approach for distal third fractures and a dorsal approach for proximal third fractures. So just a small video showing a proximal third fracture, which is being treated by a dorsal percutaneous fixation. And we see a small incision over there, and whenever doing a dorsal approach, we always do a mini open. We reach to the capsule, see the EPL and ECRL because you may damage these tendons if you are not seeing them. And then we get in access to the entry point, which is just near to the scapholunate ligament onto the scaphoid. And once we have reached the entry point is seen in the C-arm. And important thing is the direction of the guide wire should be pointing towards the thumb. And it should be right in the center of the scaphoid in all the axes. In AP, in lateral, in oblique views, you need to make sure that it is right in the center. Once the central placement of the wire is confirmed, then you measure what is the length of the screw, what is required. Usually it will be 4 millimeter less than the whole length of the scaphoid. And then we just drill on top of the guide wire. We should make sure that we don't over drill and reach to the full length because that will make the screw loose. And once drilling is completed, then the screw is just guided on top of the guide wire. Again, the placement of the screw is confirmed to be good. And once you are sure that everything is fine, we can just close the wound, and then it is okay. Now coming to the volar approach. In volar approach, we can do a total percutaneous fixation without doing much opening. And very nice important point to remember is that scaphoid actually ends at the disc crease. So many times this is a very simple point which many times we don't realize. And we always put a K-wire on top and mark the direction in which we are going to put the percutaneous wire. And many of the patients, you may not be able to go on the side of the scaphoid. So we can even go a transtrapezial and it is quite okay. It does not cause any problem. And once you are sure that the axis of the screw is central, you can replace it with a screw and confirm that it is inside in central axis in all the planes. Just showing the same boy who was having his exams, and we did a percutaneous fixation. He wrote his exam, and at 2 years we see the fracture is totally united. He has a perfect function. Another case, the video which I had shown, a good result over here, and this patient with bilateral scaphoid fixation. We did a volar approach, percutaneous for one side and dorsal for another side, and this is at 2 weeks. Patient having good union at 6 weeks itself. To summarize, you need to have a perfect indication for doing the fixation, and if you do it perfectly, I think this is one of the good operations to know, and it can be a very good for some selected patients. Thank you very much.